Okay, picture this. You're the doctor on call, and your bleep goes off. An elderly patient who came in with a simple UTI is now suddenly confused, and his blood pressure has tanked to 85/50. This is urosepsis. How you respond in the next few minutes is absolutely critical, not just for the PLAB2 and UKMLA, but for your patient's life. Let's break down exactly what you need to do. Welcome to this clinical walkthrough on the urosepsis case for UKMLA, brought to you by Medi8, your 24/7 practice partner. In this walkthrough, we're going to give you the precise structure, the key actions, and even the exact words you need to say to master this acute care station. So, you arrive on the ward, and this is what you see. An 80-year-old man, confused, with a dangerously low blood pressure. The clock is ticking. So, what's your very first move? What do you do? Right, here's the setup. You're the FY2 doctor on the medical ward. Your patient is Mr. X, an 80-year-old man who was admitted yesterday for what seemed like a straightforward UTI. But the nurses just called you because he's suddenly deteriorated. He's acutely unwell and confused. This is a classic textbook presentation of sepsis. Now let's look at his vitals, and they are screaming danger. His oxygen saturation is down at 88%. His blood pressure is 85/50. He's tachycardic at 120, breathing fast at 24 breaths a minute, and he has a fever of 39 degrees. Every single one of these is a major red flag. This patient is in shock. Before you even lay a hand on the patient, you have to nail the basics of a safe OSC station. Knock on the door, enter the room, greet your examiner, confirm the patient's identity using their wristband, and then clearly state what you're there to do. This shows the examiner you are a safe, systematic doctor right from the start. Your introduction needs to be sharp and precise. You should say this exact phrase. Hello, I'm Dr. Name, GMC number XXX. I've taken universal precautions and ensured the scene is safe. Then you turn to the patient's wristband and say, could I confirm the patient's name and age from the name tag? This is non-negotiable. Okay, now your clinical work starts. You need to immediately launch into an ABCDE assessment. But remember, this isn't just an assessment, it's simultaneous resuscitation. You are looking for life-threatening problems and treating them the moment you find them. First up, A for airway. The patient is talking or moaning, which tells you his airway is patent, it's open. But look at his SpO2. It's 88%. That's critical hypoxia. Your immediate first action is to get a non-rebreather mask on him and give 15 liters of high-flow oxygen. After you do anything, you must reassess. It's a constant loop. So you've given oxygen, and great news, his saturation has come up to 95%. That's a good sign, but he's far from safe. You have to communicate this finding out loud to the examiner. And the exact phrase you'll use is this. SpO2 improved to 95% with oxygen. I will continue monitoring. This tells the examiner you're on top of the situation and constantly reevaluating. Next, B for breathing. His respiratory rate is 24, so you need to do a full chest exam. Check for equal chest rise. Listen to his lungs. Now, since we suspect the source is his urine, his chest will likely be clear, but you must check to rule out a chest infection. The two key actions here are to order a portable chest x-ray, and, this is vital, get an arterial blood gas. You need that ABG to check his lactate level. Moving to C for circulation. His capillary refill time is more than 2 seconds. His pulse feels weak and thready, and that blood pressure, 85/50, is critically low. This combination of sepsis and profound hypotension has a name. You must say it. My concern is for septic shock. The moment you say that, you must start the Sepsis 6 protocol. And that brings us to the absolute core of managing this patient, the Sepsis 6. This is a set of 6 interventions that have to be delivered within 1 hour. Getting these done quickly dramatically improves a patient's chances of survival. Just 6 simple, life-saving steps. You need to know these by heart. Okay, let's run through them. Number 1, give oxygen. You've already done that? Brilliant. 2, take blood cultures. You have to do this before giving antibiotics. 3, give broad-spectrum IV antibiotics. 4, give an IV fluid bolus. A 500 milliliter bag of saline stat is a good place to start. 5, measure lactate, which you get from your ABG. And 6, monitor urine output, which means you'll need to insert a urinary catheter. You know, remembering all these steps and executing them smoothly under exam pressure is tough. So you can practice this exact case right now and get objective feedback on mymedi8.com. Running through the simulation makes the protocol feel like second nature. Right, you've given the fluid bolus. What's next? Reassess. You check the blood pressure again. It's crept up to 92/55. You would then say, after the 500 ml fluid bolus, his BP is now 92/55. This is a partial response. I will continue with further fluid challenges and reassess after each one. Let's quickly finish our primary survey. D for disability. His GCS is down due to his acute confusion. You'll check his pupils and get a quick blood glucose reading. Then E for exposure. His temperature is 39 degrees, so you'll give IV paracetamol. You also need to briefly expose the patient to check his entire body for other infection sources, like rashes or sores, and then immediately cover him back up to keep him warm and maintain his dignity. Okay, you've started the resuscitation. You've kicked off the Sepsis 6. That's the first half of the station done. Now you have to show off your communication skills. You need to explain what's happening to the patient and perform a perfect, structured handover to your senior. When you talk to the patient, even if he's confused, you have to be clear and reassuring. Use simple terms. You could say something like this. Mr. X, that urine infection you have has made you quite unwell. This is a condition we call sepsis. We've already given you oxygen, some fluids through your drip, and stronger antibiotics to help your body fight it. We're going to be watching you very closely. Now, for the handover to your senior, you must use the SBAR framework, SBAR. It is the gold standard for clinical communication because it's fast, efficient, and ensures you don't miss any critical information. So let's walk through it. S for situation, state the patient and the immediate problem. B for background, give the essential context, nothing more. A for assessment, give your diagnosis, septic shock, and state that you've started the Sepsis 6. And finally, R for recommendation, state exactly what you need. I need an urgent senior review, and I think he may need to be escalated to ITU. So, you've completed the initial management, you've handed over beautifully, but your job is not over. The final thing to think about is this. What are the key things you are going to monitor minute by minute over the next hour to see if your treatment is working? To put all of this together and really perfect your assessment, your management, and your communication skills under pressure, you can practice this full scenario now on mybda.com. It is the best way to make sure you're ready on exam day.